This conference will now be recorded.
Okay. Welcome, everybody, to our webinar this morning. This is the second webinar that we have had featuring Ford Koles. We at Nelson Mullins are very proud to be partners with the advisory board company, which, as I'm sure many of you know, is one of the leading think tanks in the United States. By the way, anybody who gets on this, if you could go to the middle, you probably missed this part, and hit active cameras, because I'd like to have the minimum amount of people, and you'll be listening, but your picture won't be up. So just go to the middle where it says, and hit that part about video, and hit active, click it, and then hit active cameras. And then you won't be on the picture. But if you remain on the picture, we'll let you attend anyway. So in any event, we have been involved with advisory board, which is probably the leading think tank in the United States regarding healthcare in this country, and we have been, and it gives us at Nelson Mullins a tremendous opportunity when we are representing our clients to have access to the latest information and to get very good expertise on situations where we need it, and helps us give a much better product to our clients. So the person talking today is Ford Koles, who is the executive director of the advisory board company and one of the best speakers on healthcare that I've ever had the privilege to listen to. He is the keynote speaker at annual series of meetings for us and for the advisory board company. For our firm, he's spoken at the last, I think, 4 or 5 fall conferences that we have had at the old Broad and Cassell, and then when we merged with Nelson Mullins. Unfortunately, this year, because of the COVID-19 and because everything's moved back, we're still going to have our seminar, but instead of it being in the fourth quarter, it's going to be in the first quarter of 2021. But stay tuned, because we're definitely going to have it. Ford is one of the best known and most requested public speakers in the healthcare industry, and he has been a participant in every major advisory board research initiative since 1992. So he knows this really, really well. He received his master's degree in economics from Johns Hopkins and his bachelor's degree from Kenyon College. And prior to joining the advisory board, he worked as a management consultant for both the Hay Group and Ernst & Young. So without no further ado, I'm going to turn it over to Ford. Oh, before I do, if you have something you want to chat about during the thing, if you want to ask Ford a question, this is an interactive presentation, and Ford will interrupt to answer questions. So all you have to do is go to your chat box, chat, send it to me, and I will then interrupt and ask Ford the question. So thank you very much. I hope you enjoy the seminar. I'm sure you will.
Thanks, Mike, and thank you everybody for giving me an hour of your time. I know it's hard to carve that out these days, even harder than usual. So I'm really, really appreciative of and honored that you would give me that. This is, as Mike alluded to, the second in our seminars for Nelson Mullins, Broad and Cassell. The first one was mid-April, so a month and a half ago, which seems in coronavirus time like 4 years ago. So lots to update and talk about here this morning. We really sensed that and let me just also encourage you to use the chat function. I would very much like to take your questions and your thoughts as we go. I know we have hospitals and health systems on the line that are clients. I know we have some private equity firms, and I know we have some physician organizations as well. And I definitely have some thoughts on all three to share with you today. So please do jump in and with your questions and your thoughts. So since our last conversation, obviously we have begun and in fact are well into the great national experiment of reopening the American economy, and of course, in particular, reopening the American healthcare system. So let's begin our conversation, since we haven't talked in a month and a half, with the big picture. I'll spend a little bit of time up front on where we stand with the outbreak, just to make sure that everybody's on the same page. I don't think I'm gonna break, or shock anybody here with the numbers, but I will tell you, I listen to 40 or 50 different news feeds as part of my job and doing public policy work in healthcare, and I'll tell you, you still hear radically contradictory statements coming from different news sources and public figures. So I just want to make sure that to level set here up front and make sure everybody's on the same page as to where we are with the outbreak. You can see here the general picture, sobering news, as you know, as of last week, we hit over 100,000 deaths in the United States, a sobering metric. 1.7 million or so cases identified in the United States. As I'm sure you also heard, the IHME has increased its mortality expectation now with the reopening of the economy to around 150,000 people all told by the end of this thing. That is bad news. I always like to keep things in context. I did this a month and a half ago, but I still think it's worth mentioning, which is these numbers, though sobering, are significantly lower than the unbelievably grim initial predictions that you can see on the bottom right. 500,000 Americans dying, tens of millions of cases. This is still a significant improvement on what was sort of originally imagined to be a Spanish flu level of outbreak. There has been confirmation, as you know, in the last 3 weeks in the United States and indeed in most of the Western world that we have passed the peak of the outbreak. Russia is still climbing, as I'm sure you probably have read, but Italy, the United States, the UK, France, Germany, Sweden, and in particular South Korea there at the bottom, doing notably better. And again, this is confirmed solid rolling 3-day average mortality rate in these different countries. I do want you to notice some characteristics of these lines, though, that I think are important and aren't getting a whole lot of attention in the press. Again, notice how steep the line is on the left-hand side. So the way into this outbreak, notably steeper than the way out. The lines on the right-hand side are not flat, fortunately. They're heading down, but they're not heading down with the same curve that they headed up, which was true. We had more of a U-shaped curve, if you remember, with H1N1 and SARS, and people were hoping for that, but we have not seen it. We've seen it in a few communities, but we've not seen it nationally, nor have we seen it in these other countries. So again, good news overall, but the way out of the epidemic is going to be notably slower than the way into the epidemic. And you can see the national deaths per million in the box on the right-hand side. Again, just important to note that the US, which is considered the epicenter of the outbreak from a number of cases standpoint, has not been the epicenter of the outbreak in terms of the damage, the mortality rates. And a lot of that has to do with the collapse, I think, of the healthcare systems, in particular in Italy and Spain at the height of the outbreak in those countries. So we'll talk about that as well. We see similar trends in the state-to-state data here. That New York line is important. That's the red line at the top of my slide. That's important for a number of reasons. Most importantly, the New York line, if you'll remember from the last slide, basically mirrors the American line. New York at one point was about half of the cases. Right now it's about a third of the cases in the country, about a third of the deaths. So as the New York line goes, statistically speaking, so goes the line for the nation. But good news all around. You can see a nice downward trend in New York's line, although notice there are some mini spikes. We saw the mini spikes with the country data. We're seeing a bunch of mini spikes with the state data as well. None of these have added up to a second surge. I'm getting a lot of questions, as I'm sure are you, about the civil unrest and the protests and the possibility of that being a conduit for coronavirus. Obviously, that's something we'll continue to watch carefully. We should have data, the effect of that data in terms of cases in the next 2 weeks. So we'll all be watching that. Right now, I can only tell you that these mini spikes do not add up to a second surge. Most of the epidemiologists that I've talked to still are wondering if we'll see a second surge in the fall, winter. But we don't have numbers that would indicate there's been a second surge because of civil unrest obviously, as yet. That would not show up for a few weeks. You can see good information here. I know, Mike's in Florida. Florida's down nicely. Louisiana is down nicely. California had a big mini surge, but that's now down. Illinois, again, most states doing notably better in terms of the overall 3-day rolling mortality rate. You can see some of the hardest hit cities on the right: Boston, Detroit, New Orleans, and so forth. Some of whom have had death rates notably worse than even Northern Italy. But again, the states in which those cities are located, overall doing much better than they were. This is something I tracked, and when we talked last time in mid-April, this was a big deal metric. In early March, this was the metric, which is the number of ICU or ICU bed shortages, right? ICU bed shortages. I gave you the last time that we updated it, which is late April, for the simple reason that we're not really tracking this any longer because no state right now has an ICU bed shortage. The situation in New York, the capacity was strained, but it never broke. The dam was strained, but the dam did not break. That was also true of cities like Detroit and New Orleans and Chicago. The tents are gone. The triage units are gone. And again, the American system managed it, which is just an amazing, sort of congratulations to the providers on this call, which is you handled it. The healthcare system, the ICUs in cities in Spain and in northern Italy were actually overwhelmed. Like the system essentially imploded. That never did happen in the American system, even in New York City. So again, that's just a testimony both to the excess capacity we had, which is typically a cause for complaint and criticism, but in the case of the coronavirus surge, actually turned out to be quite useful, and also the ability of providers to handle the surge and move supplies and staff around in a rather remarkable, national effort. All of the attention, so I'm probably not going to be tracking this any longer because governors aren't really using it. Hospitals are still using it to reopen, but again, we seem to be out of the woods, at least for right now with this metric. The reopening effort I put on this slide for you, I want you to look at two things. The color of the state indicates the speed with which they are reopening. And so red are the fastest moving states. The gray states are reopening a little bit more cautiously, regional reopening, we called it. And there's still more restrictions in place, at least in Illinois and New Jersey, although those states are making moves as well, as you know. There is obviously a political element to this. If you look at this map, it becomes quite clear. As you can see, it's like looking at a map of the last 6 presidential elections. Again, the advisory board is not a political shop, and I'm not interested in discussing a lot of the politics here. But but obviously, I would be denying it if I said there was no political element to this. There is. Red states are opening much faster than blue states. That is also obviously epidemiological. It's not simply a political attitude. If you, as you all know, the blue states on the coasts were the hardest hit states in terms of the epidemic. So California, New York, in the center of the country, Illinois, which is a blue state, very hard hit. Michigan and Ohio, very hard hit. Those are purple states, but again, you can see Washington State very hard hit. But again, so there is some politics to this, but also some epidemiology. The number I give you on that state is their daily testing capacity. This is not serological testing. It is actually testing for whether or not the virus is present. So a coronavirus test. You can see most states are in clear deficit. We're not nearly where we want to be, particularly hard hit. You can see Michigan and Illinois. Texas, though, way behind. California still way behind. Again, we're not at the daily testing capacity that we would want. Maryland, quite behind there, if you look at the list on the Massachusetts on the right-hand side as well. So again, there are a couple of surpluses here in the upper plains, but a whole lot of deficit on the map in terms of the daily testing capacity. Testing has gotten much better. Testing is the issue. It's not ICU bed days any longer, it's testing. And I don't want to leave you with a falsely negative impression. It has gotten much better, which I'll talk about in a minute, but we still don't have the daily testing capacity that we would want. I should note, again, you can see we haven't gotten to the level of immunity that we wanted or were hoping for. You can see New York, the hardest hit state, maybe 3.6% of the state population outside of New York City has the antibody present, maybe 21% of the city. Again, you'd want to get to 60 or even 70. I put 70 on the right-hand side in terms of herd immunity, as you know. So again, we're not there. And of course, I need not tell you that we still don't even know if the antibody gives immunity. There's some hopeful news there. Most of the time when they've found cases of people being reinfected upon closer examination, it turns out it's just sort of bits of the virus that are left and not contagious in the body. But again, we don't have official confirmation of that in terms of immunity granted, herd immunity. And we're not even close, even in the hardest hit states, to the numbers that we would want. Okay.
Before you go
Please.
on, do you would think that if we have a second tranche of this, the healthcare systems overall should be much better prepared? Do you believe that they are?
I do. I think the healthcare systems are much better prepared than they were. I think they have protocols in place, spacing protocols. The way they are bringing in patients, inpatient and outpatient, is very careful. And again, and they've stockpiled PPE. The biggest risk, Mike, I think right now, the biggest risk we're picking up on, the two major risks are long-term care. Again, as you know, this disease has manifested itself most dangerously in nursing homes. And FEMA is now giving every nursing home at least a 2-week supply of PPE that is supposed to be completed by July 4th. So that would be if we have a surge coming out of the protests, or if we have a surge that comes in the fall and the winter, we should be much better prepared, even in the hardest hit parts of the healthcare continuum, which is the nursing homes and long-term care. I will say the other big concern is rural. We have a ton of, you know the numbers, people on this call as well as I do, which is rural communities are much older. They have much higher rates of chronic disease, and they have hospitals that are not in great shape. So about half of the hospitals, for example, I was talking to a health system in Alabama. About 60% of hospitals in Alabama that are rural are already in the red. They were in the red before coronavirus, and then they took the hit of elective cancellations. Nationally, the numbers aren't quite as bad, but again, probably about 1/3 to half of all rural hospitals were in bad financial shape, really bad financial shape before this happened. So, and the other big worry with rural, is lack of broadband. So they've not been able to resort to telehealth in the same amount as we've seen in urban areas. And I should note, fewer physicians. They have about half the number of physicians per 10,000 Americans as we do in urban America. So again, I should also note, they don't have a workforce that can work from home. Almost all of the rural workforce, small town workforce, is essential. So these meat packing plants, right? Prisons, farms, these are all essential businesses. You cannot switch to working from home. So the luxury, if I can use that word after 2.5 months in my house with 2 teenagers, the luxury of working from home is not present for rural America. So lots of concerns on the rural side. I should also note, I don't want to leave you with a false and negative impression of testing. The positive rate in the United States is down to under 10%. So we're in single digits, which is where all of the epidemiologists want us to be. Testing capacity has gotten notably better across the country. And again, so we're in a much better place than we were with testing capacity. We're not there yet. And I should also note that all states are taking, Mike, to your question, preventative efforts to try to make sure the most vulnerable populations are protected. Georgia has taken an immense amount of heat, as you know, because it's been one of the fastest states to reopen. 75% of the people who have died in Georgia were in nursing homes. Or I should say were over the age of 65, not in nursing homes, but over the age of 65. Georgia has shelter in place, still in place, For anybody who's elderly or medically fragile through mid-June. That will probably be extended, I'm not sure. But again, I just want to make sure that everybody knows that no state is simply going, all hands off, let's party. There are significant restrictions in place for the vulnerable in all states still. Any other questions I can take on the epidemiology before I get into some of the longer term strategic implications? Anything on the chat function, Mike, that I should be looking at?
Nothing at this point.
Okay. All right, so that's just a quick update. And I can, again, if you have any questions or thoughts on the epidemiology or the reopening effort, I'm happy to take those. The services that are reopening fastest, a lot of people are already back to 100%, even in hard hit areas. The services that have been coming back on fastest, cardiology, vascular surgery, orthopedics has been coming back very strong. Some mixed stuff on endoscopy. I've seen surveys that say that's coming back very fast. I've had a lot of conversations though where that's more slow. Probably the three procedures to come back the slowest are going to be pain, bariatric surgery, and some of the different things that we do in respiratory care. But again, for obvious reasons. But again, you can see if you look around the country, you see people coming back very strong. I was surprised to see that that inpatient was coming back faster than outpatient. That was a little bit of a reverse of what we thought would happen. Outpatient has been a little slower. Mostly that's because of the ability to do social distancing, which people are more confident of on the inpatient side. Okay, these are the four big things that were happening pre-coronavirus. So let's talk about how much they've changed or haven't changed. Then I'll jump in deeper into each one. You can see here, single payer, obviously, there are two things on this slide which are revolutionary, single payer and spending caps. And there are two things that are more reform based. All of these things were things that we were trying to fix about the American healthcare system, largely focused, of course, on affordability. I do think affordability will remain the main issue long term, although it's already being altered. So I mentioned, for example, American effective capacity occupancy has been around 60%. That's often been a source of criticism that the American system is, overbedded and we're fat and too expensive and all of these things. I will tell you there's been a significant change in the politics of that because of our ability to handle the coronavirus surge more effectively than some of the single payer systems overseas like Italy and Spain. So I'm not hearing the complaints about occupancy from politicians that I was before coronavirus. So we'll see how long that lasts in terms of a changing political landscape. These are the four things, though, that I think we will continue to work on. Single payer is effectively gone with the removal of Bernie Sanders, the self-removal of Bernie Sanders from the Democratic presidential campaign. So single payer is off the table. Joe Biden, now the candidate, obviously identified his campaign as being opposed to single payer. He has talked all along about embracing a public option nationally. In two states, Colorado and Washington, already passed public option laws before coronavirus. Both of them have been delayed because of the financial damage to the system. But again, single payer is clearly off the table. Now, the effect of single payer will remain, which is it will always be part of the debate. Single payer has been made mainstream as part of the conversation. So it will always be out there as one of the options that we talk about in a way that it wasn't 10 years ago. So again, we're not done talking about single payer, but it has been effectively removed from the conversation for now. The real revolution is the second thing on this slide, which are spending caps. All states, all 50 states, we've seen spending caps put in place, price controls. And I will also tell you, this is utterly bipartisan. Single payer is a wholly Democratic effort that it was never embraced by the majority of Democratic senators. And again, when it's a minority of the Democratic Party, but spending caps, not support of it, but endorsement of Medicare for all, I should say. Spending caps we've seen in all 50 states it's as likely to happen in a red state as it is in a blue state. I get more stories to use on this front from Utah than I do from California, for example. So again, it's this is the real revolution: our price controls and spending caps. And I think there's nothing temporarily. I think you'll see some loosening of that as public policy makers try to give hospitals and health systems and doctors the chance for breathing room and to recover their revenue situation. But long term, I think you will see, particularly with the economic damage of coronavirus, you'll see these things stay in place. On the right-hand side are the things that providers were supposed to do in the last 10 years. One is take risk, right? We were all supposed to, as part of the Affordable Care Act and the Bush administration bundled payment programs, that we are all supposed to be slowly weaning ourselves off of fee-for-service, weaning ourselves off the drug of fee-for-service, right? That's not gone very well. Coronavirus has added some interesting new twists to this. So for example, physician organizations that are reliant on fee-for-service have been much harder hit, as you would imagine, by coronavirus and the cancellation of electives and the lack of office visits. Capitated physician groups on the West Coast, for example, have weathered this storm much more effectively. For obvious reasons, they get the majority of their payment up front. And the decline in foot traffic is not bad news for them. It's, in the short term at least, more profitable. They're more easily able to switch to telehealth, for example, in terms of a revenue model. So again, lots of things to talk about in terms of provider-borne risk. But as a national experiment, we're still not there. And then last but not least is shopping, right? All Americans with these high deductibles in the last 10 years were supposed to become shoppers for healthcare services. I have a $3,500 deductible now. I'm always complaining about it. Physicians always say to me, that's not high, $8,000 is high. Well, it feels high to me. I'm always writing a check to a healthcare entity. Now, I tell you, that's really dropped off in the last 2.5 months because nobody in my family has sought any care like everybody else. But again, we're not shopping the way we should. And I don't think this is a pipe dream. I've said to Mike before, right, that, I shop for other things. Why shouldn't I shop for healthcare, at least on some level of electives? But we don't have enough data and we don't have enough sense of control over these things to shop for them. So let's go deeper on those things. If my economics training was correct, we have 3 things we need for a marketplace, right? We need choice, we need transparency, and we need financial responsibility, right? Those are the 3 things you need for a marketplace. I'm going to give providers the first one, which is choice. I know there are healthcare deserts in Florida. There are healthcare deserts in all 50 states. There are parts of communities where we have very few healthcare providers. But overall, there's significantly more choice than there used to be. I think we can all agree on that, right? If I need to get care right now in my town, you'll find, I have an ample number of choices, right? I can go to an urgent center, I can go to CVS, I can go to Walmart, I can go to a hospital, I can go to an ED, I can go to a standalone ED, I can go to a doctor's office, I can get a doctor on my phone. Most of these things didn't exist in most markets 10 years ago. You had 2 choices 10 years ago. You can go try to find a primary care physician who's probably overbooked, or you can go to an ED and sit for 7 hours, right? So we have significantly more choices than we used to have. I can't say that there's more transparency. I can say there's more transparency. I can't really say there's more useful transparency, right? We still don't understand how to do things in terms of, the deductibles and the coinsurance, and particularly the coinsurance, right? Most Americans don't understand what that is, which adds up to a lot of anger around surprise billing. And then financial responsibility. The truth is, we have more skin in the game, but we don't sense any agency in our skin in the game. This is really, really dangerous. To give an American financial responsibility, to give them a massive deductible, but not to give them any sense that they control it, is a really dangerous thing, as you know. Makes for a lot of anger. CVS continues to push on transparency. They're not finished. Coronavirus has definitely put a wrench in this for the time being. All of these things they're talking about delaying or pushing back. So for example, as of the beginning of last year, everybody had to publish their charge master. That's already in place. There's a big lawsuit about having to publish real prices. As you know, that this was the rule passed last July. This has been pushed off, and there's a lawsuit, hanging over it anyway, in terms of getting hospitals to publish their actual prices for 300 different outpatient procedures. So again, I think you'll continue to see the government push on transparency, but I think coronavirus has probably given everybody a little bit more breathing room. Here's that Florida story I've told about. The data is not good enough for shopping, but it is good enough for shaming. So this is a story out of Florida. I thought I'd throw one in here for my friends at Nelson Mullins Broad and Cassell. Patient arrives at the ED. She was apparently visiting the Everglades. I'm sure you remember this story. She was bitten by a cat that ran by, and she tried to pet it, and it bit her. She figured she had rabies. She went to a hospital to get treated for feral cat bite and got a $48,000 bill. Now, if my guess is if you talk to the CEO of that hospital, I did not, but my guess is if you called that person and had a silent, sort of a private conversation, they never expected her to pay that bill. We claim these things in the hospital industry because we need to claim them against the charity care that we provided. Nobody thought she would pay this bill. She thought she had to pay it. So she called the New York Times and the Wall Street Journal. They called the hospital CEO and essentially a shaming took place. Tell us about this $48,000 cat bite bill. And then look at the right-hand side. When they had to publish their charge master, the price of that drug, which was, by the way, $46,000, the $48,000 was the drug treatment. The price of that drug had dropped a whopping 80% in the charge master. Not a coincidence, I would imagine. So again, everybody needs to know, and this is stopped for the meantime. Coronavirus has given hospitals and doctors a giant boost in terms of public relations, which is wonderful and deserved. So the shaming element here has ground to a halt. I was getting stories about this every single day before coronavirus. I think it will pick back up when things calm down. I do think that hospitals and physicians will benefit long-term from better PR because of their ability to respond to coronavirus effectively. But I think you will continue to see stories like this in shaming, so not enough shopping, but plenty of shaming. This is also taking place in terms of negotiation. This is a union in New York City that used the prices that they could get their hands on at the most famous academic medical center in the country. Shall remain nameless as they're a client, but you can probably guess what I'm talking about. You can see they were significantly more expensive than the community hospitals in greater New York. And this union, 32BJ, used those prices in a public relations campaign to shame that academic back to the negotiating table. And again, it was effective. They came back and renegotiated for notably lower prices. So it isn't just individuals. It's you see the transparency being used for negotiation and shaming across the board. So again, most of this has gone quiet right now. I think it will come back online though when things are a little bit more normal. The second thing to talk about is the deductible. Will we see the continued use of high deductibles? You can see it climbing. The national averages, in most markets, it's much higher than this. I think you will see more pause on the deductible front for a number of reasons. What happened coming out of the Great Recession of 2008, 2009, the social contract essentially between employer and employee was, we're not going to lay you off, but you are going to pay significantly more for healthcare. That was the number one strategy of companies trying to recover from the Great Recession of 2008 and 2009 was, if you look at surveys, the number one strategy was to do cost sharing of healthcare with the workforce. And they weren't kidding. It happened. Again, all of our deductibles are much higher. I do not think you will see the same response in the next few years. First of all, this was a healthcare crisis that brought the market down, not a banking crisis, which makes it politically very different. Second, deductibles are already very, very high in most markets. They're topping out in a lot of states. Minnesota has the highest number of people in a high deductible health plan. When I talk to employers in Minnesota, they were already topping out in terms of the deductible amount. So they were already turning to other strategies for cost savings. And I've seen that in other states as well. So I think we're in a different place in terms of high deductibles. Plus, We've had a huge number of layoffs. I hope they're furloughs. I hope a lot of people get to go back to work. But again, we've already had layoffs, so you won't see the same social dynamic that you saw the last time around. Here's the coinsurance number. This has climbed and climbed and climbed. This is sort of a silent factor because most Americans don't understand coinsurance. Even people who work in healthcare do not understand coinsurance. This also leads to a lot of surprise billing and anger. But coinsurance has actually gone up more steeply than deductibles have. Because the truth is, my company wants me to shop for that colonoscopy. They don't want me to give up, being financially incented outside of my deductible range. This will probably continue to go up because it's more of an invisible factor in the marketplace. I want you to notice this one. This is important, and I've talked to people at Nelson Mullins about this before, but this is the Walmart Center of Excellence program. Now, Center of Excellence was one of the fastest growing strategies pre-coronavirus that we were seeing in the country. The problem with coronavirus is Centers of Excellence strategies are dependent on travel. So I think there will be, at least in the short term, a big hit to this strategy. Long term, we continue to believe that this will take place. It's very popular among employers. Employers like Walmart have been able to save a lot of money using it. And when you begin to tap out on the deductible range, usually most people will say that this is the next thing they start to look at, which is how can we save money with a Center of Excellence program. Just to give you a quick overview of how it works, if you haven't seen this, Walmart started doing this in 2013. It's Walmart, so everybody paid attention, right? It's the biggest employer in the country. And a lot of other companies take their cues from Walmart. They did zero cost sharing, so they're going to make it financially easy. If you want to stay in, Kankakee, you can, but I'm going to send you to the Cleveland Clinic for heart, hip, knee, and spine procedures. Not all of them, but a hand-picked number of procedures. You can go to the Cleveland Clinic, just to use one example, or you can stay in Kankakee. If you go to the Cleveland Clinic, though, you will not be financially penalized. In fact, zero cost sharing. You'd have some locally, but you'll have none if you go to the Center of Excellence. They collected data on that program for 4 years. There were 15 Centers of Excellence that they contracted with, some of which you've heard of, Cleveland Clinic, Mayo, Hopkins, and so forth, some of which you've never heard of, or you may not have heard of. People in the healthcare industry have heard of these folks, but the average person on the street will not have heard of them. But again, 15 Centers of Excellence to come up with a reasonable geographic spread. In the middle, they collected data on that for 4 years, and in 2017, 3 years ago, Walmart made some pretty aggressive announcements, which was they started with spine surgery. People always start with spine surgery because it's somewhat controversial in these programs. But what they did was they said, look, if you want to go local, if you want to stay in Kankakee, not to pick on Kankakee, but it's a fun word to say, you can do that, but you're going to have to pay for half of the spine surgery yourself. Because you've not been a good shopper, Walmart didn't use these terms, but this is my interpretation, I'm shopping for you. And I found great places for you to receive care. So you should be going to the Center of Excellence. The care is better, fewer readmissions, fewer infections, better return to work, better productivity. Walmart has really good numbers to show the care at the Centers of Excellence is better care. On the right-hand side, as of last year, they simply mandated. They said, you have to go to the Center of Excellence or you have to pay for the thing yourself. Now, again, they were planning this year on moving to some things on the medical side. They were talking about OB-GYN, they were talking about medical cardiology, they were even talking about primary care, which would be fascinating because, it's fine to do 15 Centers of Excellence for procedures. How are you going to do it? You can't do 15 Centers of Excellence for primary care. You need thousands, right? So it was really interesting to see what they were going to do on the physician side in terms of primary care Centers of Excellence. But all of that has come, at least temporarily, has been disrupted by coronavirus. So nobody wants to travel. People are reluctant to go back to the doctor's office in their hometown. They certainly don't want to get in the car or drive halfway across the country to get care somewhere else. So again, there's been a lot of disruption to this model. I will also tell you that some of the most famous Centers of Excellence have had trouble coming back in terms of volume. I don't mean Centers of Excellence volume, I mean general volume. So I was talking to a very famous medical center in California that gets at least 25% of its business from over 100 miles away, and they got historically significant amounts of business from overseas. they are hurting. Many community hospitals have come back strong because they have great relationships with their community. They're able to put videos out on Facebook about how safe they are, all their protocols. I mentioned how much harder that is if you're gathering patients from over 100 miles away. How do you make that communication? How do you communicate that? So again, we've seen a lot of disruption to this model in terms of people's willingness to travel and use centers of excellence. I will tell you, I think you should continue to watch this strategy and investigate it and look at it and invest in it, because long term, we do think these centers will come back. It's going to take them longer. That place in California told me they anticipate at least 2 to 3 years before they're back to full volume. I've seen hospitals, community hospitals, that are already back at 100% in areas that were not as hard hit by COVID. So again, keep your eye on this, but it's a mixed bag, I think, for the centers of excellence. In terms of risk payment, that's the other major strategic issue we wanted to dive in on. What we're seeing is, and I'm measuring risk fairly loosely here. I'm including shared savings and bundled payment, which is essentially episodic risk. A lot of other economists criticize me for even including this as risk. You should only include capitation. According to many healthcare economists, that's the population-based risk models at the right-hand side. Medicare Advantage remains the most effective grantor of risk. It is the market share most people are fighting for because of that fact on the provider side. It's also the fastest growing kind of coverage because America is aging fast, and a huge number of people who are turning 65 right now choose an HMO, many more than a generation ago. Again, so lots of growth in Medicare Advantage. You can see here its growth rate, and this has not stopped in the midst of coronavirus. You can see just current course and speed. It'll be half of everybody over the age of 65 within about 6 or 7 years, just continuing the line out. And again, this was anticipated to be damaged by the Affordable Care Act. It did not happen. This grew fast during Obama, and it's grown fast during Trump. Again, so Medicare Advantage, very, very successful. This is what everybody is fighting for. On the insurance side, because it's a fast growth business with an aging America, on the provider side, because they're more likely to give us risk contracting and exclusivity. You can see here the participation rate in the ACO program. Medicare, CMS was trying very hard to move people to downside risk. I will note, I know we have physician groups and health systems on the line. Physician groups generally were more successful in the ACO program writ large than were hospital-based health systems that employ physicians. So last year, I think something like 79% of the physician group ACOs that are standalone physician groups hit their bonus numbers. Something like 33% of the hospital-based health systems did. Again, so there's been some shift in if you talk to public payers and what they see is the desirability of wide-scale physician employment, right? They're wondering if physicians do better in some of these risk models on their own, which is something which is starting to reflect itself in a lot of these programs. On the right-hand side, let me show you an example. This is coming out of CMMI, the Center for Medicare and Medicaid Innovation. The two pilots they launched last year, direct contracting and primary care first. These are focused on primary care physicians and try to get them into value-based contracting, or in the case of direct contracting, capitation directly. Now, you can do these things as a health system, but again, they've lowered the participation rates. So to be an ACO, you need thousands of beneficiaries to participate in that program. So many people have seen the ACO program as an incentive for physicians to take employment as a way of participating. They've dropped it into the hundreds. So they're trying to make it much more available to physicians who are independent and to participate that way. So you can see the rubber hits the road. We're beginning to see people put forward payer models. They do not believe would incent physicians to take a W-2 from anybody else. The North Carolina. Go ahead, Michael.
During the lockdown, primary care physicians who were primarily or totally fee-for-service were clearly hit the worst.
Yeah.
Economically. On the other hand, those who were capitated suffered. They were getting the same cash as they always did for those capitations.
That's right.
Do you think that's going to encourage more fee-for-service doctors now to try to learn how to take and start taking risks?
I do. I think it's a longer term effect. The truth is, right now, everybody's just hyper focused on getting fee for service up and running normally so that they get their cash imbalances in better shape, Mike. So I think you will see a sea change in the emotional response to risk payment, because I think physicians are smart and they see that these capitated groups have weathered the storm far more effectively than people who are heavily based on fee for service. But I think that's a longer term, sort of a more strategic and emotional impact. I think in the short term, everybody's focused on just jacking fee for service back up to where it was, because we have, significant damage has been done to the physician side. The hospital side has stabilized more effectively. Largely, part of that is the grants that were given by the CARES Act. I've heard from most CFOs of health systems, the biggest help was the accelerated payment from Medicare. Basic, as you know, these are essentially loans from Medicare for payment you would have been expected to receive that you get up front. It's a loan that if you don't document the care, you have to pay back at interest, by the way. But almost everybody took it just as a way of stabilizing their cash imbalances. Now, that's been hugely helpful in stabilizing hospital-based health systems. Help for physicians has been a little bit more piecemeal, and they've had more financial hit. This is largely because they have not recovered as fast. Foot traffic in physician offices in many markets is still 40 or 50% of normal, because they're still trying to reestablish trust in their communities. So again, and what that means is we're probably going to see, and I'll talk about this in a minute, we're probably going to see a notable increase in mergers and acquisitions. I'm sure everybody on this call already noted the acquisition of Brown and Tolan in California, by what is essentially a Blue Shield entity. Ironically, I believe an entity that was created as a way of trying to keep physicians independent. And then it intervened and purchased a massive one of the biggest physician groups in California. Everything I've read is that was a defensive move to keep somebody else or anybody else from coming in and grabbing it, other payers, or private equity, and so forth. So again, but I think that's a marker of the kind of activity you're going to see more of, which is you have private equity, holding a lot of cash, which is still dry powder, as they say in the industry, right? They still have cash, unaffected by the whims of the stock market, and you have a lot of physician groups who are right now, cash poor, and could shortly be, insolvent if foot traffic doesn't recover fairly quickly. So again, Mike, I anticipate a lot more activity in that area. This is North Carolina. Again, it was just a good bellwether pre-coronavirus of all of the things I just talked about. So you had, unsustainable cost trends. Charlotte, the 10th most expensive city in the metro area, 10th most expensive healthcare city in the United States based on prices. Lots of consolidation, as you know. I used to go to North Carolina. I'd visit like 50 different organizations. Now I visit like 3. And Blue Cross Blue Shield with a dominant market share, very similar to some other states like Alabama. Blue Cross Blue Shield is very dominant, almost monopoly dominant in the state. And Patrick Conway, who used to work for Obama at the Center for Medicare and Medicaid Innovation, took a job as the head of Blue Cross Blue Shield. So the biggest payer with a very aggressive reformer running it. He's since resigned because of a DUI. But again, we saw lots in North Carolina. That's an interesting bellwether of what we may see in other states. I'm curious as to how much of this you think we'll see. I think a lot of it will be put on hold with coronavirus, but first of all, Blue Cross Blue Shield, to get Blue Premier, you had to take downside risk. So not Medicare, but commercial downside risk. They were pushing aggressively for that. They also partnered with Aledade, a national practice management firm, to give independent primary care physicians in North Carolina help so they could participate in Blue Premier. So help with, IT, help with the back office, help with operations, as a way of getting them more efficiently able to participate in Blue Premier. This is largely a message of don't get bought, right? Stay independent. We'll help you participate in Blue Premier. You don't need to take a W-2 from either another insurance company or a hospital or health system. And then we saw Blue Cross Blue Shield importing a number of the Medicare Advantage specialty players, Iora, ChenMed, CareMore, right? These folks use small panel primary care as a way of focusing on Medicare Advantage patients. So the average panel size for adult primary care in the United States is between 1,800 and 2,000 patients per doctor. These guys had small panel care between 400 and 500 patients per doctor. So you kill two birds with one stone if you import them into a state. If you have a Medicare Advantage plan, they're effective at managing that. B, they don't work for hospitals and health systems or other insurance companies, right? They're independent players, so you're ceding independence in the marketplace. By the way, Aledade also is now being used in California for a very similar strategy. You can see the pushback I always get, right, when I talk about this in other states like Ohio or Michigan or Texas, is all the primary care physicians in my marketplace are employed. Who are they going to get, right? Who are they going to keep independent? There is nobody independent, right? But how long will that last? Again, coronavirus has probably put a big wrinkle in this. But what we were seeing in North Carolina were large defections from some of the big health systems. And before coronavirus, again, what I was being told was these weren't blips, these were trends. I know that Nelson Mullins, Brown and Cassell actually represents one of these groups in terms of the lawsuit. So again, what you see here is, what was beginning in North Carolina was a defection trend. Now, will that happen in coronavirus? Given the financial hit that a lot of physician groups have taken, this is most people speculate we'll see many fewer of these in the near term. Again, it doesn't mean we won't see more private equity activity, but that would be focused not on defection, but on groups that would remain independent that are having financial trouble. You can see here the basic breakdown in private equity activity. The private equity firms, some of which I know are on the phone, have been most focused, if I look at the deals, on single specialty medicine. They tend not to do as much primary care. It's not a perfect rule, but I don't see them as active in primary care as they are in specialty care. And the primary care disruption at the bottom, that's mostly health plans. So insurance companies, health plans aggressively purchasing primary care assets. It's followed a little more distantly by retailers and technology companies, the CVSs and the Walmarts and the, some of those different providers, but they generally focus on lower end nursing based primary care. You can see here, this is just one private equity arrangement we saw. This is in Michigan, where 5 independent orthopedic groups came together to form one huge group and built a very big, impressive surgery center where they've just shifted a huge amount of their care. Again, taking a big hit with coronavirus, like everybody else. But this is the business strategy, right? This is the disruption of the marketplace. And if you look at the private equity deals, the ones on the right-hand side, these were the 4 biggest target areas that I was watching before coronavirus: GI, orthopedics, urology, and women's health. The reason those 4, I understand, were being most targeted was they have the highest levels of outpatient surgeries that you'd be able to use that business model for. 10 years ago, it was mostly dentists and dermatologists that were targeted. As you can see, a lot of that has already been reorganized and put into the private equity model and then sold to a strategic buyer already. So nobody's talking about the rates of return that they were. I remember I went to the Nelson Mullins conference last fall. I talked to a few private equity folks in the hallways, maybe some of whom are on the call, and they told me about the returns they were looking at, which one fellow I talked to said they were looking at a return of 3 to 6% on a physician group, which of course is a long way from the return that you would have talked about 10 years ago. That's more of a typical business return than doubling your money on dentists in some of the arrangements that we saw. So there's been a huge amount of competition, lots of cash out there, which means the profit rate on these deals has gone down, as you know, significantly. For hospitals and health systems and doctors, of course, that's not a source of relief. That means that PE is involved in more deals than they used to be, rather than fewer, because the metrics or the standards they use have gotten lower in terms of participation. All right. On the primary care side, I'll finish up with this. What we've seen in terms of the disruption is a segmentation disruption. So again, you see the Medicare Advantage providers on the left-hand side focused on small panel primary care. You see the folks on the right-hand side, they actually do smaller panels as well, but they generally do it for concierge reasons. So One Medical, 98.6, Bright. These guys have been more focused traditionally on millennials, you know, and sort of technology and high service levels. A lot of folks at the advisory board use One Medical, for example, in DC. It's very popular. They guarantee same-day appointments, not with the same doctor, but they guarantee same-day appointments and so forth. Again, there have been some disruption to all these models with coronavirus, but we do anticipate seeing a continued disruption of primary care based around segmentation in the market. The biggest disruptors, yeah, go ahead, Mike.
Given everything you're saying and given the world today, what do you think the strategy ought to be for hospitals in terms of acquiring and owning physician practices?
I mean, I think what you're seeing is, Mike, you're seeing a lot of hospitals and health systems make, you know, hard decisions, you know, stuff they may have put off in the past. Coronavirus has really been has brought a laser focus to a lot of operations now. So I see hospitals and health systems, you know, making hard decisions about real estate, you know, about how many offices they have in different parts of town, about, you know, about physical capacity in terms of the hospital and foot traffic. And, you know, it's just been an interesting, you know, there is some upside to this, and that it's, I think, led to a lot more aggressive and better decision making. I think in terms of physicians, if they were losing money on doctors, I don't think anybody's making any major moves right now because physician groups have taken such a hit. I'm not seeing hospitals and health systems move to purchase them. So most of the movement I'm seeing is from payers and private equity because of the hit to the cash balances of hospitals and health systems. So again, what you're seeing is largely stasis, I think, in that area. They remain open to it, but again, I think right now you're seeing a holding pattern in terms of the physician modeling, physician compensation, physician employment in the hospitals and health systems. I believe that they will participate in future if physicians remain in bad shape. But again, I think it's right now they're in stasis because of their own damage. Okay, these are the payers who have been most aggressive. United leading the charge, Humana, Aetna, Cigna, Blue Cross Blue Shield even now participating in some of this. And again, you can see this is just one last example. This is ChenMed and Ohio Health partnering in Columbus. So in this case, Ohio Health invited ChenMed in to build 3 clinics in partnership, just as a way of boosting, you know, their ability to do Medicare Advantage care and have a segmented model. Not everybody does this. A lot of people are building these themselves, but some people are partnering to build these more disruptive primary care models in their marketplaces. Okay, that's, I hope, a good overview of what we're seeing. Again, I think this is a time to make hard decisions. Coronavirus has acted as a laser in terms of operations and performance for a lot of companies, not just in healthcare, but across the country. But again, I think it gives you a sense of what the longer term trends are, I hope, and what has been at least halted temporarily by the outbreak. Any questions I can take? I know we're out of time. So any questions I can take or thoughts from the group before I send you on to your busy days.
And by the way, if you have any questions that you want to ask and don't want to ask them on the screen, or you are think about them later, my email address is mike.segal, S-E-G-A-L, at nelsonmullins.com. If you will just send them to me, I will forward them on to Koles, to Ford, and he will provide an answer. So please take advantage of that.
Mike, everybody can jump in if they just want to unmute themselves. And
sure. If you want to unmute yourself and ask a question now, I got Ford here today.
Let me hear it.
You did a hell of a job, Ford. Nobody's got any questions.
All right. It's great to talk to you, Mike, and everybody on this call. You can always reach out to me with questions and comments, and Mike will send them on to me if you have any. But thanks very much, and everybody have a safe week, okay?
Thank you very much, Ford. Thanks for helping involved as always. Everybody enjoyed it. Take care. Thank you.
Well done.